Hello and welcome to MK's Exam Secrets. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at 6 exam questions in one clinical course. Today in this episode 4, we shall look at obstetrics and gynecology. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icons to be receiving notifications of such videos every time I post. Drop a like, drop a comment, share the link to the channel, and let's go. Grab a piece of paper and your pen. So beginning with our first question. So you have a woman at 36 weeks that's admitted to the hospital. The relatives say she has convulsed at home and is semi-conscious. Part A, what other history should be sought from the relatives? So generally when you're dealing with seizures, in general, you should ask about what happened before the seizures, what happened during the seizure, and what happened after the seizure. So the type of seizure it was, so a history of the type of seizure. So the events before the seizure, events during the seizure, what movements were being performed, and the events after the seizure. Is there any evidence of incontinence? Did they bite their mouth? Did they bite their tongue? And then ask for a history of the following symptoms. You should ask if there's history of headache, visual disturbances like double vision, blurring of vision, loss of vision, epigastric pain, right upper quadrant pain, altered mental state, if there was any dizziness or shortness of breath, if there's any vomiting, yellowing of the eyes, joint pains, any body aches, any fever that may be present, any neck rigidity or any sensitivity to light. Ask if there is a history of travel to an area that is malaria endemic. Ask for a history of them sleeping under a mosquito net or not. Ask if they have received Fansidar, which is pyrimethamine and sulfadoxine, at any of the antenatal visits. Ask if there's a personal or family history of diabetes. Ask for a personal as well as a family history of hypertension. Ask for a history of preeclampsia and eclampsia in previous pregnancies. Ask for a history of alcohol intake. Ask for a history, personal history, as well as a family history of epilepsy, and of course a history of a previous cesarean section. Then part B, what examination would help with the differential diagnosis? So on examination, if the sclera is jaundiced, this will be suggestive of malaria. If there is some neurological examination such as nuchorigidity, this is suggestive of meningitis. If there's a fever on your general examination, it's indicative of an infection. If the blood pressure is elevated, this may point towards eclampsia. Random blood sugar that is raised may be hypoglycemia. If it's low, if it's raised, it may be diabetes mellitus. And of course, a urinalysis can be done. Ketones may point you towards DKA and dehydration. Glucose in urine may point you towards diabetes mellitus, and proteins may be suggestive of eclampsia. Then what investigations would help with the differential diagnosis? So blood investigations include rapid diagnostic tests to rule out malaria, a malaria parasite slide for malaria, a full blood count with a differential to rule out meningitis, encephalitis, or even HELLP syndrome, which is hemolysis, elevated liver enzymes, low platelets. Then you may do a peripheral smear also for HELLP syndrome, which would suggest preeclampsia or eclampsia rather. Liver enzymes such as AST and ALT, which may be elevated in HELLP syndrome. Urea and electrolytes plus creatinine to rule out any metabolic derangements. You may also order for serum ketones to rule out DKA, diabetic ketoacidosis. You may also do a bedside clotting test to rule out any thrombotic strokes. Under the imaging, you want to do a pelvic ultrasound as well as a CT scan or MRI to rule out any CNS lesions. But of course, this may or may not be done. Then part D, briefly describe how the patient should be managed if it is believed to be eclampsia. So management involves stabilizing the mother, so doing your ABCs, ensure that the airway is patent and the patient is breathing, suction any secretions that may be present, give oxygen to this mother, and insert 2 large bore cannulae, and collect blood for investigations. If it has not yet been collected, insert a urinary catheter, monitor the blood pressure, and ensure that you stabilize the blood pressure using the appropriate pharmacological drugs. If the blood pressure is greater than 110 millimeters of mercury, diastolic blood pressure, then you want to give 5 to 10 milligrams of hydralazine every 15 to 60 minutes. And then once the blood pressure is less than 110, transition them to nifedipine 10 to 20 milligrams per orally twice a day, and maintain the diastolic blood pressure to less than 90. Or alternatively, you could give methodopa. Administer magnesium sulfate according to the national guidelines. So initially, you want to be giving 14 grams. So 4 grams IV, 5 gram in the left buttock, 5 gram in the other right buttock, and then obviously maintenance dose is 5 grams IM, deep IM every 4 hourly in each buttock alternating. Monitor your urine output to make sure it's greater than 30 mils per hour. Your respiratory rate should be greater than 12 breaths per minute, and you should have deep tendon reflexes. If they are not there, then there may be some toxicity, so stop the magnesium sulfate. You may give an antidote, which is calcium gluconate. Prompt delivery is actually the definitive management of this condition. So vaginal delivery, if the Bishop score is greater than 7 and they have no other contraindication to vaginal delivery, but ideally cesarean section if they have a contraindication to vaginal delivery, and if it's remotely impossible or not really possible for them to deliver vaginally. Question 2. A patient is seen in antenatal clinic at 36 weeks gestation and has a height of fundus of 26 centimeters. What important questions would you ask on history to help in this case? So this is a woman that's at 36 and her height of fundus is 26. So it means that this woman here has a discrepancy between the height of fundus and the gestational age, so it's smaller than it's supposed to be. So in your history, you ask for the pregnancy dates, because this woman would have dated the pregnancy wrongly. So you may ask for the first date of the last menstrual period, calculate the gestational age using an expected date of delivery using Nagel's rule. Ask if there's any history of hypertension in pregnancy. Ask if there's history of vascular disorders or anemia in pregnancy. Ask if this woman takes any tobacco or any recreational drugs or anticonvulsants. Ask if she has a history of intrauterine growth restriction or any maternal illnesses that she has suffered during the pregnancy. Ask if she has had placenta previa diagnosed at any stage during the pregnancy, and ask for the full nutritional history of this patient. Then what important examination findings will assist? So the blood pressure will assist in cases of hypertensive disorders of pregnancy. You may get signs of extreme malnutrition. You may get stigmata of alcohol or tobacco as well as drug abuse. You may also see that the fundal height is equal or more than 3 centimeters than the expected gestational age. In this case, I mean less than 3 centimeters of the expected gestational age. Then of course you also check for the fetal heart rate, because the fetus may indeed be dead. So what investigation would you do? So blood investigations, a full blood count with a differential for any infections, screen for torch infections, you do a urea electrolytes, creatinine and liver enzymes. Then imaging, you want to do an ultrasound to estimate the fetal weight, also do a biophysical profile, check for the volume of the liquor, check for any abnormalities. You may also do a Doppler velocimetry of the umbilical artery if it's available. Then part D, if it is intrauterine growth restriction, outline briefly management antenatally and in labor. So the management is largely dependent on the gestational age, the severity of the IUGR, the maternal as well as the fetal condition. So since the gestational age is above 35 weeks, then the management is immediate delivery. Antenatally, we want to do an ultrasound for a biophysical profile that can be done and assess the amount of liquor. Then your mode of delivery ideally should be a cesarean section. Question 3. A 20-year-old prime gravida is referred from a clinic because of raised blood pressure of 180 over 120 millimeters of mercury and 3+ proteinuria at 30 weeks. What is mean arterial blood pressure? So remember that mean arterial blood pressure is 2/3 diastolic blood pressure plus 1/3 of the systolic blood pressure. So this is the normal mean arterial pressure is around 140 millimeters of mercury. If you're assuming that the diastolic blood pressure is 80 and the systolic blood pressure is 120. Okay. I mean 100, not 140, 100 millimeters, around 100 millimeters of mercury. Then how can you bring the blood pressure down in this emergency? So give hydralazine 5 to 10 milligrams IV every 15 to 60 minutes, or you could give labetalol 10 to 20 milligrams IV every 10 minutes until the blood pressure is less than 110 diastolic blood pressure and 160 systolic blood pressure. Then you change it to nifedipine 10 milligrams sublingual if their blood pressure is still above 110 millimeters of mercury diastolic despite you giving the hydralazine. But if it has dropped, then you can use either methyl dopa 250 to 500 milligrams 3 times or even 4 times a day, or nifedipine 10 to 20 milligrams twice a day orally. And of course, your goal is to maintain the diastolic blood pressure less than 90 millimeters of mercury. Briefly outline how she should be managed. Oh, I skipped a question. Briefly outline key points in history and examination you would elicit. So on the history, check for severe headaches, visual disturbances if there's any blurring of the vision, double vision, loss of vision. Check for epigastric pain, right upper quadrant pain. Ask for vomiting. Ask for a personal as well as a family history of hypertension. Ask if she's had any seizures. Then on examination, you want to look for liver tenderness. You want to look for edema. You want to look for shortness of breath. You want to look for a raised blood pressure. And also, of course, perform an ophthalmological examination. Then the last question is briefly outline how she should be managed. So you want to admit the patient. You want to inform your senior doctors. Stabilize the patient. Ideally, you could intubate them and ventilate them if they need be. Then treat with antihypertensives as we have mentioned in part B. And of course, give magnesium sulfate, as I've already told you in the prior question. Send blood for some investigations such as liver enzymes, creatinine, full blood counts. You could also give furosemide if there's any pulmonary edema, but we rarely give this. Then delivery is the treatment, regardless of the gestational age. And since this woman is below 34 weeks or 35 weeks, we can give steroids, dexamethasone 6 milligrams IM every 12 hours for 4 doses, or alternatively we could give betamethasone. And then of course induce labor, and you aim for a vaginal delivery if your Bishop score is greater than 7, and then cesarean section if it's less than 7. So the next question is about menorrhagia. So define menorrhagia and factors that lead to it. So remember that menorrhagia is pretty much prolonged or excessive bleeding occurring at regular intervals. Okay, so you can also refer to it as hypermenorrhea. So what do I mean by prolonged? It's lasting greater than 7 days. Excessive meaning it's more than 80 mils. Then the factors that are leading to menorrhagia include things like polyps. You could have adenomyosis, endometriosis, leiomyomas, which are uterine fibroids. You could have malignancies such as endometrial and cervical malignancies, coagulopathies. You may have ovulatory dysfunction such as polycystic kidney disease. You have iatrogenic causes such as withdrawal bleeding. You may have endometrial causes such as endometrial hyperplasia and endometritis. You may have other causes such as a chronic tubal ovarian abscesses, intrauterine contraceptive devices, hyper and hypothyroidism. So if you look at the first letter of every of these that I've mentioned, it makes a nice mnemonic that's known as palm coin. P for polyps, A for adenomyosis, L for leiomyomas, M for malignancy, C for coagulopathies, O for ovulatory dysfunction, I for iatrogenic causes, E for endometrial causes, and N for neoplasms. Then, or not specified if you want, if you so wish, since I've already mentioned malignancies, and for not specified, or others. Then what are the complications of menorrhagia? Think broadly. So you could have microcytic hypochromic anemia because of the chronic bleeding. You may have high output cardiac failure because the heart is compensating for this anemia that may be there. You may have recurrent genital tract infections because as you're bleeding, it's opening up the genital tract and bacteria can ascend. You may also have psychological social withdrawal and inability to progress in school and actually even be effective at work because you're just constantly bleeding. Explain what drugs can be used in menorrhagia and how they work. So the drugs that can be used include mefenamic acid, tranexamic acid, and combined oral contraceptives. So with mefenamic acid, this is an NSAID, so it's a non-steroidal anti-inflammatory drug that's obviously going to be blocking the production of prostaglandins. And so it's going to be inhibiting the prostaglandins via inhibition of the cyclooxygenase pathway, thereby helping in reducing the pain and inflammation. Tranexamic acid, on the other hand, inhibits plasminogen activation. Thus, a plasminogen is not activated to plasmin, and it cannot catalyze the conversion of fibrin into fibrin degradation products. So this actually promotes hemostasis and prevents the bleeding. And then combined oral contraceptives, low levels of estrogen are pretty much present in the pill, and they're going to be providing this constant negative feedback on the pituitary gland and the hypothalamus, such that there's reduced production of gonadotrophins, and this person is put into a state which is a state that's known as an amenorrheic state. Then part D, outline the surgical steps that can be used in management of menorrhagia, so we can perform dilatation and curettage. This is often indicated in women that have heavy bleeding, and this heavy bleeding is leading to hemodynamic instability. Then you may do endometrial ablation, which is used as an alternative to hysterectomy when you have these other medical modalities that have failed, and if you have no other contraindications to its use. Then you may perform myomectomy in cases of fibroids. You may also perform hysterectomy, which is reserved for patients that have actually satisfied parity and other indications. Then question 5. A 19-year-old woman is seen in gynecological admission ward with left-sided abdominal pains. What aspects of history and examination would you look for to help with your differential diagnosis? So in your history, you would ask for history of amenorrhea, the last menstrual period. You would ask for history of PID or any STIs and the number of sexual partners that they have. You'd ask for their sexual history. You'd ask for the use of contraceptives. You ask if they have any vaginal bleeding. You ask if they have been fainting. You ask if they're opening bowels, if they're having any dysuria or hematuria. You ask if they're having any fever, chills, or back pain. When you examine this individual, you're going to be examining for abdominal tenderness. You're going to examine for cervical motion tenderness. You're going to examine to see if there's any adnexal mass. You're going to examine for features of shock. So if there's any pallor, delayed capillary refill time, if the pulse is tachycardic and has a weak thready pulse, or if this person is indeed hypotensive. Then what is the differential diagnosis? So this could be an ectopic tubal pregnancy. This could be gastroenteritis. It could be intestinal obstruction. It could be mid-cycle pain, which is known as mitosmetsa. It could be a spontaneous abortion. It could be a ureteric colic, which is a ureteric stone. Then what investigation can be done to help narrow down your differential diagnosis? So do a pregnancy test, Gravindex, or you can order for beta ECG. Do a pelvic as well as a transvaginal ultrasound. You can also do cholecystectomy and a paracentesis. Then briefly describe the subsequent management of this patient if it is an ectopic pregnancy. So you want to admit the patient, assess if there's any shock, so do your ABCs, obtain your IV access with 2 large bore cannulae, preferably 16 or 14G. And if they're in shock, then resuscitate them with IV fluids and a blood transfusion while you're organizing for an emergency laparotomy. So if they're not in shock and if it is ruptured, then you have to perform an emergency laparotomy with possible transfusion. If it's not ruptured, you may consider laparoscopic or even laparotomy approach. Then the last question is about pelvic inflammatory disease. So part A is define pelvic inflammatory disease. So this is pretty much an inflammation of the upper female genital tract. So it means it's inflammation of the uterus, the tubes, the ovary, and the ligaments. And so this is obviously caused by an ascending infection from the vagina and the cervix. And the most implicated organisms are Neisseria gonorrhea and Chlamydia trachomatis. Then who is prone to pelvic inflammatory disease? So patients that are below the age of 35, patients with multiple sexual partners, patients that are practicing unprotected sexual intercourse, if there's any history of sexually transmitted infections, if there's any history of them having intrauterine contraceptive devices, and of course nulliparity. Then how may a patient present with severe pelvic inflammatory disease? So explain with points on history and examination. So on history, you get a patient who comes in with a history of multiple sexual partners. You get a purulent vaginal discharge on the history. You get this bilateral lower abdominal or pelvic pain. You get this nausea and vomiting. When you examine this patient, you're going to have abdominal tenderness. You may get adnexal tenderness, you may get cervical motion tenderness, there may be a fever, and of course a purulent vaginal and cervical discharge. Then what are at least 2 later sequelae in women who have had severe PID? So they may have a tubal ovarian abscess, they may also have chronic PID, which may lead to infertility and ectopic pregnancies in future. Thank you for spending your time and listening to this review lecture video, or rather MK's Exam Secrets. Stay tuned for the next episode. If you haven't yet subscribed, please subscribe. If you haven't told your friend, please tell your friend to tell a friend that we are answering questions.